You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 29th, 2018. This week, controversy over the ischemia trial, abdominal aortic aneurysm screening, PCSK9 inhibitors and diabetes, cardiac arrest, and Twitter. First topic is controversy over the ischemia trial. Now, the ischemia trial won't likely report results for another 1 to 2 years, but this hasn't stopped the controversy over the publicly funded $100 million trial designed to test the benefits of PCI in patients with stable ischemic heart disease who have documented ischemia on stress testing. Remember that the COURAGE trial, which did not show benefit to additional PCI, did not require documentation of ischemia. Many patients in COURAGE had ischemia, but COURAGE didn't require it as an entry criteria. Now, first the controversy, then some background and some general comments. Dr. Venk Murthy and Dr. Kim Eagle, two academic cardiologists from the University of Michigan, wrote an editorial. It was accepted into the American Heart Journal, and it outlined 4 major challenges faced by the ischemia trial investigators. Now, their paper was excellent. It could be used to teach trial design. It was clear and frank. But this week, editors of the journal took the paper offline. Supposedly, there were some minor errors that were needed to be corrected. Now, the editor of the journal is also a leader of the ischemia trial. So, the 4 challenges that Dr. Murthy and Dr. Eagle outlined were, first, changes in the primary endpoint in the ischemia trial. Ischemia first set out to measure MI and cardiovascular death, but after slow enrollment and lower than expected event rates, the authors expanded the endpoint to include more softer endpoints like hospitalization for unstable angina, for instance. Another challenge with the ischemia trial outlined in the editorial was ineffective blinding of endpoints. Now, even when adjudication of endpoints are blinded, when doctors and patients aren't blinded to their treatments, this can affect softer endpoints, say hospitalization for angina. Consider subtraction anxiety. What that means is, if a patient in a trial has a positive stress test and so known coronary disease and doesn't receive a stent and then has more symptoms, that patient is significantly more likely to be admitted to the hospital than a patient who's been, quote, fixed with a stent. Now, perhaps the most notable point that Drs. Murthy and Eagle made was a call to openness and sharing of protocols, procedures, and trial results of ischemia. Remember, this ischemia trial is a very big deal. It could be the final nail in the coffin for PCI and stable ischemic heart disease, or if PCI is positive, it could reverse nearly 60 studies showing no benefit, and that could change cardiology forever. So there's already this controversy, and surely more will come when the results are released. Also remember that ischemia is an NIH study, and so data sharing eventually occurs. But Dr. Murthy and Eagle call for going a step further, and they want to release baseline data that at the same time as the current publication, and this, they say, would break new ground in openness. And it's also consistent with NIH guidance. Now, you remember this business about openness of data really came up with the landmark NIH-sponsored NINS trial. NINS, which found TPA improved outcomes in patients with stroke. It took many years for 2 independent authors to finally get the raw data. And when they finally got the raw data, their reanalysis found that the presumed TPA effect was actually driven not by the drug, but by baseline differences in the patient characteristics. But by then, TPA was already entrenched in normal therapy for patients with a stroke. So openness of data is critically important. This week, Dr. Sunil Rao, who's a leader in interventional cardiology, tweeted to me and essentially said that removal of the editorial by the editors was no big deal. It will be put back, he said, when some changes are made. And as of Thursday afternoon, just yesterday, it was back online. Now, I can't say whether it going back online was due to Patrice Wendling's excellent news story or all this noise that was made on the online space. But I feel like this conversation, the noise, the questions, the scrutiny of a $100 million taxpayer-funded trial is a really good thing. People have questioned the optics of removing an editorial that speaks plainly to the challenges of running a trial that could change cardiology. In general, more and more, people have questioned the manner in which science is being conducted. Crucially, I think, voices online have begun framing an upcoming trial results, and that's very different than what used to happen in the days of old. In the days of old, there was a vertical hierarchy, and that academic medicine of old, academic leaders could control the framing of a trial, but that's different. Now, how results are interpreted or framed is much more democratic. Now, of course, democracy means that cynical voices can come to dominate the conversation, and that's a risk. That's not good. The benefit, though, is protection against hype and spin and overreaching conclusions, and I think that is a really good thing for science. Second topic is abdominal aortic aneurysm screening. From now on, AAA screening. Now, first, a disclaimer. Screening bothers me. It intrudes into people's lives, and usually people who feel well. And some screening programs reduce the odds of dying from that disease, but essentially none of them can show reduction in overall death rates, and of course they can. It's folly to try and prevent one kind of death. There's many things that can kill us. And screening is often done in the name of helping people, but too often it ends up helping doctors, hospitals, and the medical industry. That said, AAA screening has been one of the diseases that we screen for that has been studied in RCT form. Essentially, 4 RCTs have been done. And taken together, these studies show a relative risk reduction in death from AAA rupture of about 34%, which sounds good, but it's only 0.3% in absolute terms. And keep in mind, a meta-analysis from vascular surgery authors showed no significant reduction in overall mortality from AAA screening. The problem, however, is that RCTs were done years ago, and they had plenty of heterogeneity, which means that some studies showed benefit and others did not. AAA incidence is declining, and AAA treatments have improved, and those forces would suggest screening might be less beneficial now than it was in decades ago. And so that's why a group of Swedish authors decided to look at the effects of AAA screening in more contemporary times. They could do this in this study because AAA screening was rolled out in Sweden in stages, and this allowed for a natural trial of sorts where the early regions of Sweden could be compared against the later regions. So this most recent analysis, which was published in Lancet, looked at a group of people screened in one of the first sites versus age-matched and propensity-matched cohorts from other areas that had not yet been offered screening. And after 6 years of screening, they found reductions in AAA mortality associated with screening. However, they were non-significant reductions. They did find that reductions in mortality in Sweden were similar in counties offering screening or those not, and that they found a 70% reduction in AAA mortality that was unrelated to screening. So in other words, abdominal aortic aneurysm mortality is declining irrespective of screening. Now, when they looked at the point estimate for how much you get reduction, this was non-significant reduction, but it was still, you had to screen 10,000 people, and 2 men avoided death from AAA rupture. But screening was associated with an increased risk of having elective surgery, such that for every 10,000 men offered screening, 49 men were likely to be overdiagnosed, and 19 of these men had avoidable surgery that increased their risk of mortality. Now, of course, this is a non-randomized observational study, and it had follow-up of only 6 years, and other experts have said for screening for AAA you need longer. But it does support the notion that contemporary trends in lower mortality might reduce the benefit of early diagnosis. And the important point here, the general point, is that screening isn't a sure win. Here, 2 people out of 10,000 are spared a disease-specific death, but at the cost of many more, 10 times more men having unnecessary surgery. And again, none of this makes people live longer, just less chance of dying of a AAA rupture. Third topic today is PCSK9 inhibitor drugs in diabetic patients. So a sub-study of the Odyssey Outcomes trial, which was presented at the American Diabetes Association meeting, looked at how well the drugs did in diabetic patients. And about a third of patients in the Odyssey Outcome trials had diabetes. And the question the authors asked was, does the drug have a heterogeneous treatment effect in diabetics? Now remember, the top-line results for Odyssey was that alirocumab given to patients with prior MI who are on max-dose statins, it reduced the composite major adverse cardiac outcome by 1.6% in absolute terms over placebo. All-cause mortality did not reach statistical significance, and most of the benefit in Odyssey seemed to be in those patients with LDL greater than 100. The findings of this sub-study was that the relative risk reduction of MACE, major adverse cardiac events, was similar in those with diabetes, prediabetes, and normal glycemia, and it was about 15% relative risk reduction. But what some tried to sell at the ADA meeting is that the absolute risk reduction was higher in patients with diabetes, and so yes, the drugs would be more cost-effective in diabetics. This concept brings up a really important lesson in absolute and relative risk reduction. Okay, alirocumab reduced major adverse cardiac events by 15% in all the groups. The reason the absolute risk reduction is higher in diabetics is because the rate of events was higher. Diabetic patients are higher risk. So if you take 15% of a bigger number, it's going to be larger. This doesn't mean there are heterogeneous treatment effects. It just means if you are higher risk, there is more benefit to be gained from a 15% relative risk reduction. This is different than the findings from the IMPROVE-IT trial with ezetimibe. Remember, in that trial, the benefits from ezetimibe combination appeared to be exclusively in patients with diabetes, so that looked to be more of a heterogeneous treatment effect. Now, as you all know about PCSK9 inhibitor drugs, the main barrier to using these things are the cost per event saved. And the second barrier I think is relevant are that the trials are short-term, couple, 3 years, and there are unknown unknowns on the matter of long-term risk of this degree of cholesterol lowering. Fourth topic today is improving survival in cardiac arrest. Now, there are two ways to improve survival after cardiac arrest. One is to prevent it from occurring. The other is fast treatment when it occurs. A study from Northern European authors published in the British journal Heart looked into the association of the density of AEDs, automatic external defibrillators, and survival from cardiac arrest. And they used 4 cohorts of out-of-hospital cardiac arrest from 2008 to 2013. Now, though this study was retrospective and observational, the analysis included over 22,000 arrests, of whom 13% of people survived. There were about 4 major findings from this analysis. The first was that overall survival after out-of-hospital cardiac arrest was increasing over this time period. Secondly, the proportion of survivors defibrillated by first responder AEDs has also gone up significantly. Most importantly, the proportion of survivors who received their first defibrillation from an on-site AED rose from 14% to 30% in 2013. And so survivors of out-of-hospital cardiac arrest are increasingly defibrillated by non-EMS AEDs. And these treatments are associated with increased survival. And so that one of the authors of the study, this means that public defibrillation performed by lay people is probably saving lives. And I highlight this study because there's a lot of talk about screening for conditions that cause cardiac arrest, say mass ECG screening of athletes to identify conditions that could cause cardiac arrest. But as I've already discussed screening, the problem with efforts to screen is misdiagnosis and iatrogenic harm, not to mention that there's no convincing data that ECG screening works. Now, we don't need RCTs to know that AEDs work. We know that. What this study shows is that the greater use of AEDs by the public improves survival. So if you want to prevent people from dying, say on sports fields or anywhere, use more AEDs, have them available, and train the public to use them. Fifth topic today, final topic, is about Twitter, good or bad. I wanted to point you to a nice feature video from Dr. Michelle O'Donoghue, who is a cardiologist and clinical trialist from the Brigham and regular contributor to the Heart.org Medscape Cardiology. The title of her talk is Does She or He Who Tweets the Loudest Rule? And my favorite line in her piece is this, when she says, when it comes to journal publications that are peer-reviewed and editorials, they tend to be fairly well-balanced and even-keeled in terms of how the data are presented and the reactions as well. And then get this, what she says, for Twitter, there is none of that. It allows people to really say what they believe. Now, I think that last comment gets to the heart of the new order of scientific discourse. And pause on that for a moment. Twitter allows saying what you really believe. And I agree with that. People do say what they really believe on Twitter. But the converse of that statement is, in peer-reviewed, editor-protected journals, what are the invited writers, the editorialists, the key opinion leaders actually saying? Are they saying exactly what they believe, or are they saying mostly what they believe, or what it's safe to believe? Is there a hint of pragmatism in the fairly well-balanced and even-keel reactions from journals? Remember, friends, those that help you understand studies and journals are often those that do the research and work in professional societies, and they need goodwill amongst the funders of their research to keep doing that. When you read, quote, even-keeled interpretations in journals, you should remember the role of pragmatism. Now, that said, one of the biggest risks from Twitter and social media, in my opinion, is to get close to cynicism, and I want to avoid that. I want to avoid that because we've made great progress over my career in cardiology. And this has been due in large part to those who are doing the science and collaborating with industry. Researchers are moving us forward. That said, my final comment today will be that I sometimes think moving science slower and maybe making fewer mistakes would actually lead to faster progress and accelerate patient care, make patient care better. So that's it for This Week in Cardiology, and I want to make a couple announcements. First is that next week, This Week in Cardiology is off due to the July 4th holiday. And then I also want to alert you to the third week of July, July 20th. I'll be taking family vacation in southern Kentucky on a beautiful lake with my family, so I'll miss that week. But then the schedule will otherwise be normal. So I'm grateful that you listened today. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.